Differential diagnosis of schizophrenia. 1. Boundary with schizoaffective disorder. The diagnoses of schizophrenia and schizoaffective disorder are intended to apply to the current or most recent episode of the disorder. In schizoaffective disorder, the symptoms of schizophrenia are present concurrently with mood symptoms that meet the full diagnostic requirements of a mood episode and last for at least 1 month, and the onset of the psychotic and mood symptoms is either simultaneous or occurs within a few days of one another. 2. Acute and transient psychotic disorder. The psychotic symptoms in schizophrenia persist for at least 1 month in their full, florid form. In contrast, the symptoms in acute and transient psychotic disorder tend to fluctuate rapidly in intensity and type across time, such that the content and focus of delusions or hallucinations often shift, even daily. The duration of acute and transient psychotic disorder does not exceed 3 months, and most often lasts from a few days to 1 month, as compared to a much longer typical course for schizophrenia. In cases that meet the diagnostic requirements for schizophrenia except that they have lasted less than the duration required for a diagnosis in the absence of a previous history of schizophrenia, a diagnosis of other specified primary psychotic disorder should be assigned. 3. Boundary with schizotypal disorder. Schizotypal disorder is characterized by an enduring pattern of unusual speech, perceptions, beliefs and behaviors that resemble attenuated forms of the defining symptoms of schizophrenia. 4. Delusional disorder. Both schizophrenia and delusional disorder may be characterized by persistent delusions. However, hallucinations that are consistent with the content of the delusions and do not occur persistently, i.e., with regular frequency for 1 month or longer, are consistent with a diagnosis of delusional disorder rather than schizophrenia. Delusional disorder is generally characterized by relatively preserved personality and less deterioration and impairment in social and occupational functioning in comparison with schizophrenia, and individuals with delusional disorder tend to come to clinical attention for the first time at a later age. Individuals with symptom presentations consistent with delusional disorder, for example, delusions and related, circumscribed hallucinations, but who have not met the minimum duration requirement of 3 months should not be assigned a diagnosis of schizophrenia even though the combination of persistent delusions and related hallucinations technically meets diagnostic requirements for schizophrenia. Instead, a diagnosis of other specified primary psychotic disorder is more appropriate in such cases. 5. Boundary with moderate or severe depressive episodes in single-episode depressive disorder, recurrent depressive disorder, bipolar type I disorder, and bipolar type II disorder. Delusions during depressive episodes may resemble delusions observed in schizophrenia, and are commonly persecutory or self-referential, for example, being pursued by authorities because of imaginary crimes. Delusions of guilt, for example, falsely blaming oneself for wrongdoings, poverty, for example, of being bankrupt or impending disaster, perceived to have been brought on by the individual, as well as somatic delusions, for example, of having contracted some serious disease, and nihilistic delusions, for example, believing body organs do not exist, are also known to occur. Experiences of passivity, influence or control, for example, thought insertion, thought withdrawal, or thought broadcasting, may also occur in moderate or severe depressive episodes. Hallucinations are usually transient and rarely occur in the absence of delusions. Auditory hallucinations, for example, derogatory or accusatory voices that berate the individual for imaginary weaknesses or sins, are more common than visual, for example, visions of death or destruction, or olfactory hallucinations, for example, the smell of rotting flesh. However, in a moderate or severe depressive episode with psychotic symptoms, the psychotic symptoms are confined to the mood episode. 6. Boundary with manic or mixed episodes in bipolar type I disorder. Psychotic symptoms may occur during manic or mixed episodes in bipolar type I disorder. 7. PTSD and CPTSD. Diagnoses of post-traumatic stress disorder and complex post-traumatic stress disorder require a history of exposure to an event or series of events, either short or long-lasting, of an extremely threatening or horrific nature. Symptomatic manifestations of primary psychotic disorders: positive symptoms, negative symptoms, depressive mood symptoms, manic mood symptoms, psychomotor symptoms, cognitive symptoms. International Classification of Diseases, ICD-11, includes the option of providing a specification of the level of severity for 6 symptom domains. Each of these symptom domains can be recorded as not present, none, mild, moderate, or severe. The ratings should be made based on the severity of the symptoms corresponding to that domain during the past week. In cases where multiple symptoms fall within a particular domain, the rating should reflect the most severe symptom within that domain. The rating of depressive and manic mood symptoms in these specifiers indicates the severity of depressed, elevated, or irritable mood, and does not include other symptoms, for example, disrupted sleep, anhedonia, appetite change, that can occur as a part of mood episodes. Symptoms attributable to the direct pathophysiological consequences of a comorbid medical condition or injury not classified under mental, behavioural or neurodevelopmental disorders, or to the direct physiological effects of substances or medications, should not be included in the specifier ratings. However, in individuals with schizophrenia or other primary psychotic disorders, the specific etiology of symptoms is often unclear, for example, whether a mood symptom is due to the psychotic disorder or a result of substance use. In these cases, the relevant symptom should be considered in making the specifier rating until it becomes clear that the pathogenesis of the symptom is unrelated to the primary psychotic disorder. 6A25.0 Positive symptoms. Positive symptoms include delusions, hallucinations, most commonly verbal auditory hallucinations, disorganized thinking, formal thought disorder such as loose associations, thought derailment, or incoherence, disorganized behavior, bizarre, purposeless and not goal-directed behavior. And experiences of passivity and control, the experience that one's feelings, impulses, or thoughts are under the control of an external force. 6A25.1 Negative symptoms. Negative symptoms include constricted, blunted, or flat affect, allergy or paucity of speech, avolition, general lack of drive, or lack of motivation to pursue meaningful goals, asociality, reduced or absent engagement with others and interest in social interaction. And anhedonia, inability to experience pleasure from normally pleasurable activities. 6A25.2 Depressive mood symptoms. Depressive mood symptoms, as reported by the individual, feeling down, sad, or as observed by the clinician, for example, tearful, defeated appearance. If suicidal ideation is present, a rating of moderate or severe depressive mood symptoms should automatically be applied. This specifier may be used regardless of whether the depressive symptoms meet the diagnostic requirements for a depressive episode. The 6A25.3 Manic mood symptoms. The specifier includes elevated, euphoric, irritable, or expansive mood states, including rapid changes among different mood states, i.e., mood lability. It also includes increased subjective experience of energy, which may be accompanied by increased goal-directed activity. The severity of associated non-mood symptoms of a manic or hypomanic episode, for example, decreased need for sleep, distractibility, should not be considered in making a rating for this specifier. 6A25.4 Psychomotor symptoms. Psychomotor symptoms include psychomotor agitation or increased motor activity, usually manifested by purposeless behaviors such as fidgeting, shifting, fiddling, inability to sit or stand still, wringing of the hands, stereotypy, and grimacing. Psychomotor symptoms also include psychomotor retardation, restlessness with purposeless motor activity to the point of exhaustion, posturing, waxy flexibility, negativism, mutism, or stupor. If the full syndrome of catatonia is present, the diagnosis of catatonia associated with another mental disorder should also be assigned. 6A25.5 Cognitive symptoms. Deficits may appear in any of the following cognitive domains: speed of processing, attention/concentration, orientation, judgment, abstraction, verbal or visual learning, or working memory. Thanks for watching.